Right. We have Dr. Ghajar with us. He is the president of the Brain Trauma Foundation and the director of the Brain Performance Center here at Stanford. And he's also the organizer of this event, so thanks for putting up such an event. And
sure.
I have some questions, if that's okay.
Yeah, go ahead, shoot.
So many people refer to concussions as an invisible injury because of a lack of definition that's widely accepted and difficulty in diagnosing it. So what do you think are the next steps in concussion diagnosis?
Well, I think we have to first find out what's really wrong with people. There's a change in brain function. And so what's a change in brain function? And then you have to sort of go back and say, what's the brain really doing when it's normally functioning, you know? And I think we sort of think of the brain as getting information, getting sensory information in, and then having motor function or executive function outside. So there's the brain is constantly engaging with the environment and interacting. And the problem is, we have a fundamental problem, is that the brain's in the past. Everything you sense has already happened. And so it's actually impossible to be in the present, literally. And so mindfulness and all that, being in the present, it's absolutely impossible. As long as you have a neuron between you and the present, you're in the past. So it takes time to process information. So the only way to be in the present is to be in the future. And so the brain is built for prediction. It's a prediction machine. And most of it's built for prediction, because if you don't predict, you're not in the future, you're not going to be in the present. You won't catch the food, you'll die. So the food is moving, usually. And so that's in the old days, caveman. So it's really about prediction. So I would say that the brain dysfunction that happens after concussion is really a failure of prediction. And that explains a lot of things in concussion, why people feel fuzzy, dazed, out of sync, while they can't interact well, they can't, when they're listening to people talking, they don't catch the words because they're not predicting correctly. And so, so we have to measure it. And I think right now we're using eye movements because your eyes move, but it's not really a vision thing, it's just your brain moves your eyes and you can see how well it predicts. And so we can have a predictable target, like a dot going around a circle, and we can see how well your brain predicts the trajectory of the target and if it lands right on the target. We can measure the jitter of the target, and so we can see how well you predict. And we can have that also when you're moving. So when you're moving, you have to send predictive signals from your body to your eyes. And you can also see how well you maintain your gaze while you're moving. So, so I've found in my clinic, and a lot of other people have found, that there's certain types of problems with people, and we're labeling them as subtypes, because we can measure these things and we can correct it. So let's find out who's got it. So measuring things that are moving in the outside world, how well do you follow them? It's predictive eye tracking there. And then there's vestibular, where you're trying to maintain fixation, gaze fixation while you're moving, predictive signals in your body. And then I'd say a neck whiplash. One of those three, all those three produce the symptoms. So migraine headaches, cognitive fatigue, anxiety, depression, sleep problems, I would say are caused by one or all of those three. That's the working hypothesis that many people in the country are going with. And we're calling it subtypes of concussion. We are trying to educate physicians to measure these things in people, and if they have a problem looking at things that are moving in the outside world, you can train them. If you have trouble moving and keeping your fixation, you have vestibular balance training. People who have persistent migraine headaches can go to the headache clinic, get treated. But a lot of these symptoms disappear when you correct the problem. So for right now, that's it. But then you get into what's the biology, And I think what we have, not everybody has all these problems. Some of them cluster. And the way you get your head injury, the way you snap your head, causes some stretching of fibers differently in different people. And also that people have things that they bring to the concussion, the baggage. A lot of people have prior migraine headaches, they may have prior sleep problems, they may have prior anxiety, depression. Those affect their current symptoms. And so you have to take that into account as well. But I think a lot of these problems are, the prediction problems, are from cerebellar connections to oculomotor and vestibular nuclei in the brainstem, and also prefrontal cortex. So all these areas in the brain need to have timing prediction. There's where things are going to be and when things are going to be. And I think the when part is really critical, and that's what happens in concussions, gets disrupted.
Right. Right. And I guess I want to highlight what you said about the concussion subtypes and people bringing baggage into the concussion.
Mm-hmm.
How do you think the new classification of concussions in these subtypes will impact patients who have had prior concussions? Does that also change the treatment?
Yeah, that's a very good point. And so we may have to modify the subtypes of concussion to look at their baggage that they bring. Prior concussions. Another one is ADHD, learning disabilities, ADHD. There could be gender has an effect too. Women, age has an effect. So younger kids may have a little bit different injury than older. So we have to bring that into the equation as well. But I think the first thing is to bin people according to how they cluster with these subtypes. Then, as you say, bring in these other premorbid or what we call baggage they had before. Bring that in. But it's just separately. People who had prior concussions might tend to take longer to recover. Some of them have developed sort of a migraine headache syndrome where even a slight hit to the head can cause symptoms. And so you think that maybe the head injury is triggering just migraines, And so it gets difficult. But I think the more we can measure and the more we can type people, the better off we'll be in treatment.
Right, right. And I guess taking our discussion to the sidelines, such as in the football game and into the context of sports, how do you think that will change looking ahead after we start widely using these subtypes and eye tracking, for instance?
Yeah, I mean, and there are other tests you can do on the sidelines to try and figure out what subtypes they have. I think on the sidelines you really want to figure out if they're disoriented, because if they're they're not doing which is prediction. They're predicting their body in space and time so they can interact. And so you want to pick that up, because if you send a player back into a contact sport, they'll get injured, and they'll be far worse off. So you want to measure it, and probably you want to measure before even they go onto the field. I mean, sleep is a big deal. Sleep, for instance, affects orientation, your attention, your ability to predict. And so there's a paper that just came out last week showing that it was a Pac-12 study actually in Arizona, showing that students who are sleep deprived have almost a 3-fold increase in concussions. And we also have a paper in press right now showing that people who have eye tracking abnormalities at baseline that look like sleep deprivation also have a 2.5-fold increase in concussions. So I think we're going to move from, sideline is important. How do you pick people out? I mean, you're going to wait for them to stagger before they may have. So I think surveillance is really big. So like before the people go into play, you have to make sure they meet a certain threshold so they won't get injured. That'll decrease the injury rate dramatically. But that said, I think on the sidelines, the best thing is to figure out if they're oriented. So they can have the problem with the finger going back and forth. You don't know if they're really following it. You can go by symptoms, which is the VOMs.
Right.
You move their head back and forth. You can look at balance and all those things. But it's got to be a quick test. You don't want to take a long time. But the main thing is you want the athlete to really pay attention. That's what you want to assess. And there's a lot of words like attention, orientation, prediction. They're all the same kind of things. It's selecting information in time and space so you can then process it. And you could call it synchronization, a lot of different words for it.
Yeah, and I guess to wrap up, in the discussion you moderated with Steve Young, former 49ers quarterback, we talked a lot about this idea in current professional sports that suggests that to be tough is to play through a concussion. So how do we change that logic?
Yeah, so I think these crash courses here, they have VR headset training kids how to tell their coach they have symptoms, because if you tell them they have symptoms, they can correct it and get them back into play a lot faster. Yeah.
All right. Well, thank you very much. That was great.
All right,
Thank you so much.
You're welcome. Thank you.